is Patrick Ryan. I'm a third-year medical student at Tulane University School of Medicine. And on behalf of my team, I'm going to present our project, Outcome and Effects of Demographic Factors in MPFL Reconstruction with and without Concomitant Tibial Tubercle Osteotomy for treatment of patellar instability. Here's a list of our relevant disclosures. So to start and give some background about our project, patellar instability is an injury that most commonly affects a younger patient population. For example, pediatric patients have been found to have up to a 6 times greater incidence of the injury than in the general population. The condition is also found to be more common in females than males. In terms of treatment, non-surgical treatment can be used to correct patellar instability. However, as many as 43.1% of patients can experience recurrent instability following this intervention, in which case surgical treatment is warranted. While there's a host of operative treatments for this condition, our study focused on just 2 surgeries for correcting patellar instability. First, we looked at MPFL reconstruction, the most common approach for management of this condition. This makes sense as the MPFL is estimated to account for 50 to 80% of stability of the patella and is injured in almost all cases of patellar instability. We also examined MPFL reconstruction with tibial tubercle osteotomy, otherwise known as TTO. This procedure is indicated in patients with specific anatomical abnormalities, such as a TT-TG distance greater than 20 millimeters and trochlear dysplasia. For this project, we specifically focused on comparing postoperative complication rates between patients in each of these surgical cohorts through a large-scale study. We also sought to investigate how demographics affected patient outcomes. Patient data for this project was collected using ProLiver, a de-identified national claims database. Surgical cohorts were created using ICD-9 and 10 codes specific for patellar instability and CPT codes for MPFL reconstruction and TTO. Patients were excluded if they were under the age of 10 years, over the age of 40 years, had previously been diagnosed with knee osteoarthritis, or had previously undergone ligamentous knee surgery or arthroplasty. All procedures took place from January 1st, 2010 to September 30th, 2018. Each patient cohort was queried for baseline demographic data and clinical characteristics such as age, sex, Charlson Comorbidity Index, and rates of diabetes mellitus, hypertension, and tobacco use. Rates of postoperative complications at 1 and 2 years, such as infection, knee stiffness requiring operative intervention, patellar fracture, and revision MPFL reconstruction, were compared via univariate analysis and multivariable logistic regression. Like other studies of patellar instability, ours found that patients who received surgical treatment for this condition were overwhelmingly young in age. More specifically, 56.8% of our sample was between the age of 10 and 19 years. Additionally, our study found that isolated MPFL reconstruction, that group had a significantly higher proportion of patients in the 10 to 14 years of age range when compared to the other studied age ranges. Our authors speculated that this finding may be due to surgeons opting to not use TTO in skeletally immature patients with anatomical abnormalities that would normally warrant the procedure due to fear of growth arrest and recurvatum deformity. Further, the MPFL reconstruction with TTO cohort has a significantly higher proportion of patients in the 15 to 19 years of age group. Use of concomitant TTO was likely proportionally higher in this age group because the anatomical abnormalities that warrant it tend to present earlier in life. So patients in this group were either being diagnosed with chronic patellar instability for the first time and therefore underwent the appropriate treatment, or may have underwent conservative treatment prior to reaching skeletal maturity, so that they could be better surgical candidates for TTO. This table, if I can just get straight in, this table displays a comparison of demographic data between each surgical cohort. As you can see from the arrows, there was a significantly higher proportion of tobacco use in the MPFL reconstruction group and a significantly higher proportion of concomitant MACI use in the MPFL reconstruction with TTO cohort. The significance of the latter finding may be questionable, however, due to the very small sample size of patients undergoing additional cartilage restoration procedures, specifically MACI and OAT in this case. Our data also did show a higher percentage of females in the MPFL reconstruction with TTO group when compared to the MPFL reconstruction alone cohort. This finding did not reach significance, however. When comparing postoperative complications between surgical cohorts, it was found that the MPFL reconstruction with TTO group had a significantly larger proportion of patients that needed MPFL reconstruction within 2 years when compared to the MPFL reconstruction alone cohort. Our authors speculated that this finding may be in part due to skeletally immature patients with anatomical abnormalities receiving MPFL reconstruction rather than MPFL reconstruction with TTO. Multivariable logistic regression analysis with the MPFL reconstruction with TTO cohort as the reference group reaffirmed our univariate analysis findings, and that patients who underwent MPFL reconstruction with TTO had a significantly lower rate of undergoing revision MPFL reconstruction at 2 years. Further, our analysis showed that independent of index procedure, patients in our study that were under the age of 21 years had a significantly lower rate of requiring procedures to correct knee stiffness and experiencing any of the complications we queried at 1 and 2 years when compared to patients who were over the age of 21. This aligns with past research that has displayed a correlation between increased age and postoperative complications and other orthopedic injuries, such as knee dislocation. Male patients were also found to be less likely to require procedures to correct knee stiffness at both 1 and 2 years when compared to females. The literature shows that female patients are generally over 5 times more likely to experience complications following MPFL reconstruction than males. This may be due to a higher incidence of anatomical abnormalities, such as trochlear dysplasia in female patients. Finally, tobacco use was also found to be associated with a significantly higher rate of postoperative infection at 2 years. The connection between tobacco use and increased risk of postoperative infection is widely supported in the literature. Nevertheless, there are some limitations to the study. First, our lack of direct access to patient records prevented us from measuring the proportion of patients with anatomic abnormalities and surgeon reasoning for including concomitant TTO or not. In terms of outcomes, incidence of specific complications may have been underestimated. For example, we may have not been able to capture all patients who experience some level of knee stiffness following surgical intervention because we required that patients undergo manipulation under anesthesia to be included in this outcome measure. Further, TTO-specific complications such as non-union and painful hardware requiring removal were not included, so that a similar complication profile could be directly compared between groups. Finally, our comparison of each surgical method could be confounded by poorer overall results in the MPFL reconstruction with TTO group due to potential predisposition for less favorable outcomes in patients with pre-existing anatomical abnormalities. To conclude, our study found that the MPFL reconstruction cohort exhibited higher rates of revision surgery at 2 years when compared to the MPFL reconstruction with TTO group. In terms of demographic factors affecting patient outcomes, patient age under 21 years was associated with lower rates of any complication and requiring procedures for knee stiffness. Male sex was associated with a lower rate of requiring procedures for knee stiffness, and tobacco use was associated with a higher rate of surgery for postoperative infection. This information can be used to assist surgeons when counseling their patients before undergoing their procedures and to better understand their likelihood of different outcomes or complications. Here's a list of my references. It was a pleasure speaking to you all today. Thank you for having me. Any questions?
I have a question. Did you normalize for age when assessing the tobacco users? Because the tobacco users might in generally be a little bit older. If that's.
Yeah, we actually didn't normalize for age. We put it in our multivariable logistic regression analysis, and tobacco use as an independent variable was assessed. It was just a yes or no response, so not in terms of packs per day or anything like that.
Was there information?
Oh, sorry about that.
I might have missed female sex information. Did you compare male to female?
Yeah, we did. So we found that females were more likely to require procedures for knee stiffness, and this was kind of backed up by the literature. Females are more likely to have anatomical abnormalities such as trochlear dysplasia, so they're 5 times more likely to have complications after these type of procedures.
All right, any other questions?
All right, thank you,
Alrighty.
everybody.